Anyway, if you want to skip and we move to the next doctor, no problem. You can case while you're fresh.
No problem.
Okay, great. So if you slept in the middle of the case, it's okay. I'll try to keep you awake.
Inshallah.
So this is a simple case, inshallah. It is 60. She is Mrs. Azza Kamel, and she is 63 years old, referred by her GB. I don't know why I have problem with her and his in all my slides. Referred by her GB for severe recurrent epistaxis. Okay?
Okay. This patient 5?
Yes.
Okay.
You have 2 minutes. Tell me once ready, okay?
Okay. Okay. Hello?
Can you start, doctor?
Okay. Good afternoon. I'm Dr. Sharif, senior house officer in the hospital. Are you Mrs. Azza?
Yes.
And are you 63 years old?
Give me a second, doctor. I'm looking for the timer. I don't know what it is about the time. Give me a second, please.
Sorry?
Give me a second because I'm looking for the timer.
Okay, no problem.
Just a second. I got it somewhere.
Okay.
Okay, doctor.
Good afternoon. I am Dr. Sharif, senior house officer in the hospital. Are you Mrs. Azza?
Yes, doctor.
And are you 63 years old?
Yes.
Nice to meet you, Mrs. Azza.
Nice to meet you.
I'm here to discuss with you your problem. Is it okay for you?
Yes, sure, doctor.
So can you tell me what's going on?
Yes, doctor. I have this recurrent bleeding from my nose. I don't know. I don't know what's going on, doctor. It was before mild, but recently it's become more frequent. It happened every few days, and the last time it was severe enough, and I felt dizzy at that time.
I'm sorry for that, Mrs. Azza. When did this was started actually?
Actually, it started since years, but it was never severe, doctor. But in the last few months, as I told you, the frequency increased.
Okay, I'm sorry for that. I understand from you this is progressing.
Yes.
Okay. Anything that increases bleeding?
Increasing the bleeding, no, doctor.
Anything that can stop its bleeding? Do you use any medication, any maneuver?
Yes, I'm just making compression on my nose when this happened, and that's it. And I need to go. I went to the ENT doctor before for that. So this is what I'm doing usually. In the last time, all these measures didn't succeed, and that's why I decided to take it seriously.
And did you admit it before, or you received the blood before, Mrs. Azza?
No, doctor.
Okay. Are you taking any blood thinning medication?
Blood thinning medication, no, doctor.
Do you have any bleeding from any other orifice?
No, doctor.
Do you have any family history of bleeding?
Family history of bleeding? Yes, doctor. My father, he died at 45 by intracerebral hemorrhage.
I'm sorry for that, Mrs. Azza. I'm sorry for that. Okay, Mrs. Azza, can I ask you some few questions? Do you have any anemia? Any dizziness? Any blackouts?
I have dizziness, doctor.
Okay. Any weight loss?
Weight loss, no, doctor.
Any decrease in appetite or weak appetite?
No, doctor. My appetite is okay.
Any bleeding from your back passage?
No, doctor.
Any difficulty in swallowing? Sorry.
You what?
Yes.
Yes, I noticed. Yes, I noticed some occasional bleeding coming with my back passage.
Okay, I'm sorry for that. Is it red blood or red blood, or is it black food? Black food.
No, it looks like red blood, doctor.
Okay, I'm sorry for that. Do you have any pain in your back passage?
Pain in my back passage? No, doctor. No pain.
Okay. Do you have any difficulty in swallowing?
No, doctor.
Okay, Mr. Azza, if you don't mind, can I examine you while talking?
Yes, sure, doctor.
Okay. Can I see your eyes? Any pallor?
Yes, there is some pallor.
Any yellow discoloration?
No, doctor. No yellow discoloration.
Mr. Azza, do you have any pain in your face and your nose?
In my nose? No, doctor.
If you don't mind, can I examine your nose?
Yes, doctor. Nothing obvious.
No polyps, no nothing. Okay, Mr. Azza, do you have any pain in your mouth and your chin?
No, doctor.
Can I examine your mouth? Can you open your mouth?
You mean my oral cavity? Yeah.
Yes.
There is some drops of. Let me show you.
Okay.
This is the palate floor. Roof, sorry.
Okay. Do you not any of these drops in any other part of your body?
Yes, over the chest, doctor, and in my face. You see, there is 2 or 3 in my face.
If you don't mind, can I look through them?
You see the picture on the screen.
Yes, I know. Okay. Mr. Azza, do you have any other lash except this, other than this?
Only I told you on the chest. I have 2 on the chest.
Okay, Mr. Azza, do you have any swelling in your tummy?
No, doctor.
Any pain? Any tummy pain?
No.
Any problem with your water work?
What do you mean by problem?
Any increase in the water work frequency? Any blood red urine?
No.
Any froth urine?
No. 2 minutes remaining, doctor.
Have you been traveled abroad recently, Mr. Azza?
No, doctor.
Okay. Mr. Azza, can I know what's your concern?
Yes, doctor. My concern, I want to know what's going on. I'm worried to die like my father. My father died with brain hemorrhage. There were
Yeah,
bleeding in his brain. So will I have the same?
I'm sorry for that, Ms. Azza, and I'm sorry to tell you that you have a problem that is running in family. It is called hereditary hemorrhagic telangiectasia. It will lead to thinning of your blood that makes you to bleed, as what happened in your nose before. And what I can see that you have now a serious bleeding. We might need to admit you to the hospital at the time being to carry some emergency blood tests and see your hemoglobin, and you might need to have consultation with the nose consultant and the blood consultant for that. Is it okay for you, Ms. Azza?
Yes, doctor, sure.
Okay, Ms. Azza. Do you have any other concern?
No, doctor, that's all. So if you will take care of that, I'm okay.
Okay, Ms. Azza, thank you. I will arrange for your admission to the hospital now. Ms. Azza, I forgot to ask you, do you smoke?
Yes, I'm smoking, doctor.
How many cigarettes?
5 cigarettes a day.
And do you drink alcohol?
Occasionally, doctor.
Okay, I advise you to that we should quit smoking, so I can arrange you appointment in the smoking cessation. The clinic that will be better for your case. Is it okay for you?
Yes, sure, doctor.
Okay, thank you, Ms. Azza. Do you have any other concern?
No, doctor, I'm okay.
Okay, thank you, Ms. Azza.
Okay, thank you, doctor. So time finished. So it is, what's your differential diagnosis? We'll start at 2 minutes, then we will see the examiners. What's your diagnosis?
My first differential is hereditary hemorrhagic telangiectasia. It's one of my first differential. My second is was any other bleeding problem. I put a drug cause, but she's not taking drugs. I put other bleeding symptoms.
What other type of hereditary hemorrhagic diseases you know?
After hereditary, I have hereditary spherocytosis, but it usually come with hemolysis, and I would find yellow eye in her eyes, and also the age is not.
Yeah. What about Volvo-Brand?
Sorry,
What about
actually.
Volvo-Brand?
Volvo-Brand disease, I think it would come in earlier age than 60s, and it could contain any obvious source in the trauma sites like knee or any other joint.
So no nasal bleeding with the Volvo-Brand?
I think it could have occasional nasal bleeding, but I think it will present early in life, not.
Okay, what about hemophilia?
I think also hemophilia will present early in her life because in a young age, something like that, because the patient for sure will have any interference, for example, teeth broken or something like that, it should present early.
Okay, and usually it came in male or female hemophilia?
Usually it can be male also.
Okay, doctor, what other differentials, what other bleeding type you may expect in this patient?
I might expect to have some problems related to
time
count.
Doctor, time finish.
Okay.
Okay. So now scoring time. Give Dr. Sharif score. Wow. Not wow. Dr. Noman, you will not be examined, inshallah. You will be a successful candidate, but not examined. You are very tough. Okay. So most of them give you between 24 and 28, Dr. Actually, I see no reason to give you less than 26. Okay, so good examiners will give you a full mark. Average examiner will give you 26 or 25. You did very well. You reached the correct diagnosis. You do reasonable, relevant examination. You went through the structure. You didn't give me the feeling of the time restriction. So this is very nice. And you were quiet and no anxiety in performance, and this is very nice. So I like your speed. You are asking fast without hurrying up, and you are not anxious. So I appreciated that, Dr. Sharif.
Thank you.
Okay. In general, otherwise, everything was okay. This is yes. This is hemorrhagic telangiectasia, hereditary hemorrhagic telangiectasia. Don't ask me why very common in the exams. It's very common in the exam. Okay. Just a second. It's very common in the exam usually. They just bring a patient and they give him the history and they draw a fake red spots in his skin and around his lip, and they consider it go as a hereditary hemorrhagic telangiectasia. Give a history, family history of serious bleeding. Okay, and that's it. So you can see it in the exam. So you need to know exactly how to deal with the hereditary hemorrhagic telangiectasia. So let me just show you the hereditary hemorrhagic telangiectasia. It can be presented in the exam. Look at this slide, please. It can be presented by epistaxis, by anemia, by GI bleeding, by red urine, by weakness. Any of these can be the presentation of hereditary hemorrhagic telangiectasia. Okay. The questions, as usual, you have this slide just to remind yourself. The question hereditary, so you ask about the family history, bleeding, then you will check this type of bleeding, then rash, the telangiectasia. For the bleeding, you will notice the anemia, as we said, or the symptoms of anemia, the pallor and the dizziness and all these you ask about. Brain hemorrhage, so you will ask about any history of weakness, numbness, or any lateralization, or any gait, any stroke, any mini stroke. Then the chest, any coughing out of blood. I want you to ask in this order in order to show the examiner that you know that bleeding can come anywhere, even internally. So coughing out of blood, okay? Then GI, vomiting, throwing out of blood, or black stool, or vomiting of black vomitus. Then any red urine. So show the examiner that you know that bleeding can be internal in the brain, the chest, and the GI, and the immune system. Then the rash. Then when you go to examine, yes, as you did, ask about taking a look by your torch in the nose to see if there's active bleeding. Look in the mouth to see if there is posterior epistaxis. Sometimes there's epistaxis posterior going down in the throat. Okay, and look for telangiectasia inside. And sometimes telangiectasia on the palate, as like our patient here. Look to the palmar stool for the pallor. Okay, look for, ask to examine the abdomen. Okay, again for the hepatomegaly. Okay, neurologically, okay, you need for anemia. The patient may have numbness, and maybe may have if he has any neurological bleeding or intracerebral bleeding, the patient may have weakness or numbness or whatever. So ask, say, I would like to examine neurologically. If the patient mentioned anything about numbness and weakness, any attack of TIA, then for the chest, ask to examine the chest by the stethoscope to check if there is any signs of intrathoracic bleeding. Usually they will not say, they will say do what you want and you'll do everything that will come back normal, because if the patient is in this condition, he will not be a candidate for the exam. So investigation, I will do full blood count, stool in blood, urine in blood, urine for blood, stool for blood, and CT head and abdomen angiography if actively bleeding. So if there is doubt about any of these, we will do this blood works. For the treatment, in the mild cases, we do nothing. Sometimes we need to give iron. If the patient asks you, I have a problem with this red dots, do you have anything to do with? You can tell it, I refer you to the skin doctor who's concerned about that, and he may they may do cauterization. In severe cases, they give estrogen, okay, in the treatment of telangiectasia. Okay, I didn't mention the differential diagnosis yet, Dr. Adam. I will go to the differential diagnosis again back, but this is for hereditary hemorrhagic telangiectasia. This is what to ask, what to examine, how to answer the question about investigation and treatment, because this case is very common in the exam and it is a simple case. If you don't know anything about it, it could be a big problem. If you know it, it is a full mark case. You should get a full mark in this case because it's a simple one. Here for the differential, because Dr. Adam asking me. So the first thing in the abstracts I want you to do, ask about onset course and duration. Is it the first time? Is it coming from one nostril or two? Because usually if it is just an organic or local cause of the abstracts, it will be unilateral from one side that needs cauterization and done. You need to check the severity of the anemia. Ask about dizziness, collapse, failure. Every 1 point of these, you will lose marks if you didn't ask about. So if you didn't ask about the dizziness, you didn't ask about the collapse and the pallor, the examiner will be very unhappy because it's a simple case, so they're expecting you to do everything. Okay? Then here, the causes. There is 4 bleeding questions. Do you remember them? Personal history of bleeding, other history of bleeding, okay, from any other orifice, family history of bleeding, other blood thinning medication. Okay? I'm just trying to eat one grape because I have run out. So 4 questions. We'll ask them about the previous bleeding, 4 questions, and any other bleeding. So other bleeding, as I said, give him options. So when you ask the 4th question in this case, give option. Other bleeding, ask him about, as we said in the hereditary hemorrhagic telangiectasia, with bowel motion, with coughing, weakness, with urine, with bleeding under the skin. So this is the second question. 3rd question about the family history. And as I told you, just write that down, write this slide because you will receive it only like that. Family history, there will be hereditary hemorrhagic telangiectasia, which is autosomal dominant. There could be hemophilia. But in hemophilia, there will be known blood disease. You'll ask, do you have any known blood disease since birth? In history of joint bleeding. Remember something. This was in the basics. Hemophilia causes factor bleeding. And von Willebrand causes what's called platelet bleeding. Because in von Willebrand, although the platelet count is normal, but the function is impaired. So the patient will have platelet bleeding with normal platelet. What I mean by that, platelet bleeding, when the patient has thrombocytopenia, the bleeding is bruises under the skin, nasal bleeding, some dental bleeding, and menorrhagia. This is the platelet bleeding. The factor bleeding usually deep. The factor bleeding can cause hemofibrosis and can cause internal hemorrhage bleeding. Although platelet thrombocytopenia can cause that, but usually the thrombocytopenia presented initially when it's bleed by the type of bleeding of epistaxis and paresis. But when the platelet is below 10,000, there could be a serious bleeding at any organ. There could be intracerebral hemorrhage. And when it is below 50, that's why we are giving the patient platelet when his platelet is below 10, whatever, what if he has hemorrhage or not. And we are giving them platelet if there is any history of bleeding and the platelet count is below 50. Some hospitals and some guidelines saying below 30,000 platelets. So remember, when the family, when I ask about family history, I'm asking about hereditary hemorrhagic telangiectasia. So I ask about the rash. Ask about family history, other family members with bleeding, and other type of bleeding or previous attack of bleeding. Ask about hemophilia if she's known or he's known to have blood disease, any previous history of joint bleeding. Then von Willebrand, there will be prolonged bleeding after tooth extraction or after procedure, and there will be a family history as well. And there is nasal and menstruation, excessive menstruation. So in von Willebrand, it is autosomal dominant also. The hemophilia is X-linked, but the von Willebrand is autosomal dominant. So there will be family history, nasal bleeding, history of prolonged bleeding after procedure like dental extraction. Then the 4th question of the hemorrhage, as usual, medication. Ask about aspirin, ask about anticoagulant. Okay, so this is the 4th question. Other differentials, yes, there is other differentials for bleeding. Thrombocytopenias, as we said, TTB, there is severe thrombocytopenia with neurological symptoms, with possible blood clot or bleeding, and renal and neurological symptoms. So this is TTB. Severe cases usually will not appear in the exam. It should be a new differential. So neurological, renal, blood clot, and infection. Sorry, and HUS syndrome also, hereditary syndrome. There can be bleeding. Then ITB that happen after exclusion of the other causes. Sometimes happen post infections, but it is idiopathic without a reason. And usually this case came in the exam twice before. The ITB, you can read it in either. A case of ITB. Your rule will be to exclude every other cause. Then you will say this is ITB. There will be splenomegaly, and the treatment will be splenomegaly. Then the last thing is the DIC as a cause of bleeding, and here there could be a history of excessive blood transfusion, severe infection or sepsis. These are all cases. Actually, this is not a basis, but this should be in your mind. So DIC, ITB, TTB, HUS. There is some also infections like hemorrhagic viral infection. If you are living in Saudi Arabia, in Jeddah, there is what's called dengue fever. So there is hemorrhagic viral infection. The patient have mosquito infecting him with this virus, and the patient have a thrombocytopenia, low platelet count, and sometimes there is serious bleeding happening. Usually it's self-limiting. We call it hemorrhagic viral infections. Then the last thing is, the last 2 things, liver disease. Patient with liver disease will have tendency of bleeding because of thrombocytopenia and lack of also formation of coagulation factors and vitamin K. Okay. The last thing is vasculitis. Patient with vasculitis, Wegener, there could be bleeding, polyangiitis. Okay, so Wegener and HSP, Hench-Lim purpura. This can be associated with bleeding. Again, it's a long differential, but I want you to know all these for bleeding. Just to make it simple, on the right side, check the severity of anemia. On the left side, ask the 4 questions. In the 4th question, the personal bleeding, other bleeding. When I say other bleeding, I want you to mention the bleeding in the renal, lung, kidney, blah, blah, blah. Okay? Then you will go to the 3rd question, 4th question about the family history, 3rd question. So remember, von Willebrand, hemophilia. Then the 4th question will be about blood thinning medication. Okay? Then other causes of low platelet or bleeding, thrombocytopenias, including ITB, TTB, DIC, liver disease, and vasculitis. Just to have the differential, the common case coming in the exam is hemorrhagic telangiectasia or hereditary hemorrhagic telangiectasia. Okay? Okay. Dr. Shazia.
Yes.
How are you?
I'm good, thank you. How are you?
Is it 4 a.m. now?
It's for what? Sorry.
What's the time there now?
It's about 250.
Oh, you are good. Can you take a case or you will make a noise?
No, it's in daytime. It's in USA.
It's what?
I'm in USA, so it's a daytime.
You're in USA, so okay, so it's a daytime. Good.
Yeah.
Okay, great. So you'll take the next case.
Yeah, sure.
Okay. And you're enjoying the Thanksgiving.
I'm enjoying your lectures for the last 2 days, so I'm not enjoying Thanksgiving.
So you lost the Thanksgiving.
Every year we'll don't go out for that.
What?
It's too cold to go out.
Okay. So what we'll do in Christmas. Okay. So let's proceed. So this is the case, Dr. Shazia, and this is Mr. Walter Matthew. He's 73 years old. Mr. Walter Matthew, thank you for seeing Mr. Matthew, who works as a part-time bookkeeper at a local church-run library. He's usually fit and well, but recently complained of having developed shaking of his hands and is dropping books at work. He's worried that he may have Parkinson's disease. He takes aspirin for a previous TIA, which had 6 years ago. Please see and advise.
Okay.
You have 2.5 minutes. This is history station, okay?
Okay. Thank you.
Good luck.
Okay, Dr. Han.
Okay, doctor, can we start?
Yeah, sure.
Okay, let's start.
Hello.
Hello.
Is this Mr. Walter Matthew?
Yes.
I'm Dr. Kanwal and I am doctor on duty here today. So can I confirm your age, please?
Yes, doctor, I'm 73.
Okay, thank you so much. And I have a letter from your GP that you are having some problem with your hands, and we are here to discuss about that. Can you please tell me more about what you are having?
Yes, doctor. I started to have these handshakes since 8 months.
Okay.
And actually, these handshakes become more obvious recently. And I noticed that this happening to me while at work, while I'm doing my work. Actually, I can't keep a tea cup in my hand.
Okay.
And I'm very worried about that because I have Parkinson. I have a friend with Parkinsonism, and he suffered a lot with that. And I'm very worried to be the same as what happened to him.
Oh, yes, I can understand your concern. Definitely, you will be worried about that, but we will try our best to help you out with that. But let me ask you questions. I want to know in detail exactly what you are having. So you are telling that you are having tremors for the last 8 months, and you are getting worse with time, right?
Yes.
Okay. And so is it in one hand or in both hands?
In both hands, doctor.
Okay. Any other part of your body having tremors, like your legs or head?
Yes, doctor. I noticed that my head. Sometimes my head showed. My wife told me that I'm doing abnormal movement by my neck.
Okay. Okay. And you're telling that you have more tremors than you do any work, right?
Yeah.
Have you ever noticed any tremors when you put your hands are on table or?
No, during the rest, you mean? No, during the rest, it's okay. I have nothing.
Okay. And when you are having your hand in a fixed posture, right? At that time, you are having those tremors.
Yes.
It's holding a cup.
Yeah.
Do you have any problem in writing something?
Sometimes, doctor. Yes. While I'm writing, sometimes I notice that also I have this.
Okay. Do you have any problem with your gait?
With my gaits, no, doctor.
Okay. And so anything that you felt that makes your tremors better?
Like what, doctor?
Anything that can improve? Have you ever noticed?
No.
Okay. Or anything that make it worse?
I think while I'm working, I start to notice that more than while I'm watching TV for example.
Okay. Have you noticed if you are having any stress or any anxiety that makes your tremor worse?
I'm not sure, doctor.
What do you think? Mature people don't have any type of depression, anxiety?
No, doctor. I'm not sure. I didn't notice if this is
Okay.
related.
You are not sure. Okay. 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 Do you have any other family member who is having the same problem?
I told you I have my cousin, and he's my friend, and he has Parkinsonism before, but he died. He died by the complication of his disease.
I'm sorry to hear that. Okay. Okay. I'm sorry. Okay. And are you able to do your other daily work, your routine work?
Yes.
Any problem in doing those?
For sure, there is some problem. I'm telling you that I can't carry a cup of tea. I can't do it, but usually I start to have troubles. I'm dropping the box from my hand, and I'm dropping a cup of tea from my hand also. So you know.
Okay. So, Mr. Matthew, do you have any other medical condition?
Yes, doctor. I have a history of mini stroke that happened since 6 years ago.
Okay.
And I'm taking aspirin for that.
Okay. And you're okay after that for the last 6 years?
Yes.
Okay, good. And anything else?
No, doctor. I'm good.
Are you taking any other medication?
Only multivitamins.
Okay. Okay. And how's your appetite?
It's perfect, doctor.
Any change in your weight?
No, not really.
Have you ever noticed any swelling in your neck?
No.
Any chest pain?
No.
Palpitations?
What?
Any racing of your heart?
Yeah, no, doctor.
Okay. Any problem with your bowel?
No, doctor.
Any problem with urine?
No, doctor. It's normal.
Okay. So, any previous hospitalization?
No, doctor. Only when I have this mini stroke. I was hospitalized for 1 day.
Okay. In which you work in a library, right?
Yes, doctor. I'm working as a part-timer bookkeeper.
Okay. Do you do any other work?
No, doctor.
Okay. And who else is living with you at your home?
My wife, doctor.
Okay. Do you smoke?
Yes, doctor. I'm a smoker.
How much do you smoke?
I'm smoking 15 cigarettes a day.
Have you ever thought about quitting smoking as it's dangerous for
Yes,
your health?
Yes, sure. I hope to be able to do that.
Okay, great. Then I will definitely refer you to the smoking cessation clinic.
This
And
would be great.
okay, good. And do you drink alcohol?
Yes, doctor.
Okay, how much?
I'm drinking on the weekend excessively, but in the weekend I'm drinking half a bottle of scotch.
Okay, and that is also not good for your health, heavy drinking.
Okay.
Okay, we can help you out in this matter too. Have you ever noticed that is there any change in your tremors after drinking?
Yes, I usually feel perfect after drinking.
Yes. Okay.
I'm not thinking about quitting alcohol.
Sorry.
I'm not thinking about quitting alcohol. It improves my condition. It improves it.
Okay, but heavy drinking is not good for your health. You can maintain a healthy drinking.
Okay.
Yeah. Okay. And have you ever your wife noticed that you're having shaking while you are sleeping?
While I'm sleeping, no, I am not sure. She didn't tell me something like that.
Okay. So, Mr. Walter, so your concern is main concern is that if you're having Parkinson's. Anything else that you want to discuss?
No, doctor.
Okay. Whatever, Mr. Walter, you have told me, for me, it is more likely a benign condition that is called essential tremors, and that is only physiological. And but we need to rule out the other possible causes of tremors. But right now, Parkinson's is not my first diagnosis. My first, I'm thinking about the essential tremors, and it's a benign condition that can improve with some medications. And
Okay.
but we will run few tests. We will
Can it come to here, doctor? Can it get worse?
it can worse, but definitely when we will start medication, that will help you a lot.
Okay.
Controlling, yes. And anything else?
No, doctor. It's a good news. If this is not Parkinsonism, I'm very happy for this news.
Yeah, but we will definitely sorry.
2 minutes remaining.
Definitely we will do some test to rule out your.
Okay. Hello. Hello, doctor. Hello. You lost the connection, doctor, or what? I can't hear you. So, doctor, can you hear my voice? You hear me, right? Yes. So, Dr. Shazia, your mic stopped. She went out. She will re-enter. Re-log in. So we're waiting for Dr. Shazia to appear again. Okay, so what about giving her a score? Can she come back? Let her come back and found her scores there. Out of 20. Out of 20. This is a history case.
Hello. Sorry.
Hello?
I'm sorry. Something went wrong.
Okay. No problem. Okay, so you have 1 minute.
Okay.
You still have something to say?
No, I think it's okay.
Okay. Okay, so they started giving you scores. Some give you between 14 and 18 over 20. Okay. So now question, what's your differential diagnosis, doctor, for this patient?
My differential diagnosis for this patient was essential tremor, and then Parkinson's disease.
Okay. What else? What other causes of tremors?
Yeah, there are some diseases can cause like have tremors in liver diseases, renal.
Yeah, liver disease.
Hyperthyroidism.
Okay, anxiety.
Anxiety, yeah.
Right.
Physiological tremors, yes.
Okay, great. So this is your differential. How would you proceed with this patient?
Most likely that depending on his history, it looks like he's having like essential tremors. So I'm not thinking about Parkinson's. So we can give him beta blockers to control the tremors.
You give him beta blockers, good.
Yeah.
Do you think we need to include anybody with you?
Neurologist. I am a neurologist.
Whenever you are asking this question, doctor, whenever you ask about what are you going to do, again, remember the non-pharmacological and pharmacological and the non-pharmacological. I told you before, don't say non-pharmacological and pharmacological, but this means you need to mention that in your, what are the components of that? So
okay, we will involve occupational therapist. That we can
I would say I will reassure the patient. First of all, this is what I will answer professionally. I will reassure the patient, okay, that his symptoms is not going with Parkinson's, but we still need to be assisted by a neurology specialist. Okay. So education of the patient about his condition. This is non-pharmacological, right? I'm telling him what it is. This is part of the management. So patient education, okay, about his condition, advising him about controlling the amount of alcohol, okay, because he may excessively drinking because this is the way he's improving his symptoms, right?
Yes.
Then including the neurologist, okay, to examine the patient clinically and exclude the Parkinsonism, for example. Okay. Sometimes occupational therapy, is it important or not?
Yes.
Don't you think occupational therapy is important? The patient has a problem in doing his daily activity, so he needs some physical therapy and occupational therapy to help his daily activity. And you need to advise him about carrying hot stuff, right? Or no need?
Sorry?
Do you need to advise him regarding carrying hot objects, dealing
Yes.
with hot things, working in his car, for example, acting with dangerous devices?
Yes.
Right?
Yes.
Yeah, so you have time in the case. So when you have some extra time, and this is a common case given the exam any time before. And this type of the cases, you will get the diagnosis in the first 3 minutes, and you still
Yes.
have 11 minutes. So you need to exclude the other causes. You need to show the examiner that you know the other diagnoses and exclude them. Okay, and you need to give the patient reassurance, education, go through the structure. Okay, and check the things like what I'm telling you, advising him regarding smoking, alcohol, dangerous machines. Patient, and this patient, if he next day he carry a hot tea and this fall over his body or whatever and goes burn, okay, you would be responsible because you didn't advise him regarding not to carry hot stuff. Okay, not
Okay.
to work in dangerous devices. So this is important advice, right?
Okay. Yes.
And when
Thank
you
you.
do that, you will impress the examiner as well. Okay.
Right. Yes.
You did very, very well. You reached the correct diagnosis. You get the correct management plan, although it needs a little bit to be more organized for the management plan. But otherwise, everything is okay. You catch the essential tremors. You catch that it is a kinetic tremors. Okay, that present during action, not during rest. You asked about other family history, and you asked about the intubation or the head affection. So all these are the criteria that we use to confirm a diagnosis of essential tremors. Okay, the last question: if this case is persistent and becomes very severe, do you know any recent treatment for this condition?
No.
Okay, surgical treatment.
Okay.
Did you hear about something called deep brain stimulation?
Yeah. Yes.
So deep brain stimulation is a new treatment for any abnormal movement. In Parkinsonism, in essential tremor, in Korea, in any disease with abnormal movement. Deep brain stimulation. This is electrodes they insert inside the brain, okay, connected to device, controlling, and it shows great results. Watch it on YouTube, you will see how much it helped the people with abnormal movement. Deep brain stimulation. It came on time also for, you need to have an idea about that because if it came, I'm not sure if it came or not, if it came in the exam for explaining procedure, although it's a surgical thing, but why not? Just try to have an idea about it, okay? Some more information will be helpful. But it is, if he asks you about that, this would be your answer. They ask you this question for Parkinsonism frequently. What is the surgical treatment, okay?
Okay.
Good,
Thank you.
Thank you, Dr. Shazia.
Thank you so much.
Thank you. Okay, thank you. So the next slide for the tremors. Again, tremors, there is onset course and duration. Okay. So you will ask for just a second. For the tremors, you will ask. In the tremors, you will ask about onset course duration. Is it resting or is it during action? Okay. The difference between the resting tremors and the action tremors, there is different type of action tremors actually. You don't need to know the details exactly, but remember that there is action tremor and rest tremors. The rest tremor that happen at rest, it can be part of Parkinsonism. Okay. Sometimes it can occur with severe essential tremor. So when there is a severe essential tremor, it may show resting tremors. But for the exam, resting tremors not essential tremors. Resting usually Parkinsonism. For the action tremors, you have 3 types. They are all almost the same. You have postural and kinetic and intention. To make it simple for you, the kinetic that happen when you are going to do voluntary movement. Okay, and this present in essential tremor, cerebellar, drug induced. So the patient going to do any action, kinetic action. So voluntary movement. So the patient going to write, to grasp something, his tremors increase, and this is called kinetic. And this present in essential and even in cerebellar. Okay, the postural, it depends when the patient raises his arm against gravity. Okay, so when the patient extends his arms, for example, against gravity, this is called postural. And again, it's present in the cerebellar, physiologic, and essential. So it's the same. So why the need to know the difference? Nothing. The intentional, it is subtype, the intentional tremor, the subtype of the kinetic tremor. Okay, and it happened when reaching the object. Okay, on reaching the type of the and usually it's related to the cerebellum. So when you try to do that patient with the cerebellum, when he's going to touch his nose, the tremors increase aggressively at this moment. Okay, so anyway, I don't want to confuse you. You are tired enough. There is action tremors and there is rest tremor. The action can be postural, kinetic, and intentional. Don't care about the details. Just remember to call the one for the cerebellar, call it intentional tremors. Okay, for the essential, it is mainly what's called kinetic or postural. Okay, so for the tremor, as onset course duration is resting or action tremors, and outside again, you will go in approach 2. So you will write outside your differential diagnosis in order to ask about when you go inside. How will I do that? Simply. My plan is to make analysis like what Dr. Shazia did. I will go and make analysis for the tremors. Can you tell me more about your handshakes? Okay, is it resting or action? It started suddenly, gradual, increasing, decreasing. Then I will ask about the neurological symptoms. I will ask about my differential. Okay, so here remember the word Dr. Wilson help. Dr. Wilson help. The D, okay, refer to drugs. So I need to ask, when I write Dr. Wilson help outside, I remember one doctor when he passed the exam, he told me, once I see tremors outside, I remember this moment when we discussed this in the course. So he wrote it, Dr. Wilson help, okay? So the D for drugs and drugs that cause shakes, write it in the chat box. Any doctor who slept already, please wake up and write in the chat box the drugs that cause handshakes. Salbutamol, agree. Beta agonists, what else? Lithium and salbutamol, agree. What about thyroxine? What about cyclosporin? What about tacrolimus? So patient coming with renal transplant, with tremors, we need to consider tacrolimus and cyclosporin, right? Thyroxine, cocaine, I agree. Thiophelin, agree. Lithium, salbutamol. Methylbromide will not cause handshakes. Methylbromide will cause more. It will cause more extrapyramidal symptoms, including all the body will be shaking. And phenytoin, I agree. Tricyclic antidepressant, I agree. Valproate, valproic acid. So tricyclic, valproic. So all these medications. So having a amphetamine, having a drug history, that any medication that can cause handshakes is very important. What about the C letter in doctor? So there is nothing about there is the C letter. Okay, cerebellar. Okay, and in cerebellar you need to remember Danish. Who knows Danish? Do you know what's Danish? It's a very common mnemonic for cerebellum. The Danish are the symptoms of the cerebellar. Danish, the D for dysdiadochokinesia. the A for ataxia, the N for nystagmus, the I for intentional tremors, the S for the speech abnormalities, the H for the hypotonia. So again, the Danish is a known mnemonic, not mine. So the D, this is the dyskinesia, the A for ataxia, N for nystagmus, the I for intentional tremor, the S for speech, the H is hypotonia. I will discuss that in detail in the neurology day. In the neurology day, we will go through that in details. But anyway, I want you to know that the first C for cerebellar, and these are the symptoms of the cerebellum, and you need to examine that. If the case is patient 5 and patient with handshakes, you need to do cerebellar examination. You will ask the patient to do that. This is the dyskinesia. He will try to show you the coordination. He's clubbing with his plantar and dorsal side of one hand on the other hand, and you need to do that fast in both sides. Then the A, you will let the patient walk with support and check the ataxia. You will look to the I, moving with nystagmus. You will look for intentional tremor by let the patient touch his nose by his arms while you are doing support. The S, you let the patient to tell you his address, which usually is I am living in the, there is something like expulsive speech. Then the H for hypotonia. There will be hypotonia in the muscles. Then renal, okay, respiratory failure. The RFE, I mean respiratory failure. Although renal failure also can cause it, but anyway, respiratory failure. Okay, patient will have retention of CO2, and retention of CO2 usually causing tremors. Okay. That's why the patient with COPD, you will see that he has tremors, not only because of the treatment, but also because of the usual respiratory failure they are suffering of and the retention of the CO2. The Wilson, for Wilson disease. So in Wilson disease, there will be yellowish discoloration of the sclera, there will be a handshake, there will be family history, there will be tummy pain, there will be darkening of the skin. Okay. The H for what? Hyperthyroidism. Hyperthyroidism coming and dancing. You need to ask hyperthyroidism. If you didn't ask, the examiner will be mad at you. You need to ask about excessive sweating, about neck swelling, about, as you said, the handshakes, about the heart racing, about the insomnia, about the lost motion. All these symptoms of hyperthyroidism you need to exclude. The A refers to essential tremor. And in essential tremor, okay, you will write that it may include the headache, the head, sorry, it may be in the head also. So it is action tremors. Can affect the head, presence of family history, and improve with alcohol and beta blockers. Okay. So as we said, can affect the head, presence of family history, okay, action tremors, decrease with alcohol and beta blockers. Usually it is worse on sustained position, and there could be what I said, head titubation. Then the L refers to liver disease. So patient with liver disease can have tremors. For sure, you will let the patient extend his arms and see his flabby tremors. Then the P refers to 3 things which are very important. The first one is Parkinsonism. And in Parkinsonism, you will ask what's called TRAP. TRAP. So please write it, TRAP. I think you have the slide. So write TRAP, please. The T refers to tremors, which is resting tremors. Then the R is rigidity, the lead pipe and the cogwheel, rigidity. The A refers to akinesia. There is akinesia or bradykinesia in a patient with Parkinsonism. He's very slow in his actions. So akinesia. Then the P for postural instability. The patients with Parkinsonism, they have postural instability, so they may fall down at any moment. So patient coming with recurrent falling, very common case in the exam, very common case. No exam in UK without no diet, without Parkinsonism. It will be in station 3, it will be in station 5. There should be a case of Parkinsonism. They are fond of Parkinsonism, very common case in their country. We are very weak in dealing with Parkinsonism, so they like to examine and test Parkinsonism patient. So remember, TRAP, postural instability, it comes with patient with recurrent fall, and that's it. And I will tell you exactly how to deal with the case of Parkinsonism because it's super important. Then the last S for the speech, the patient with monotonous speech. So this is what's called TRAPS for the Parkinsonism. The other P here is physiological tremors. As we said before, I didn't say that with you, so for the patient with anxiety may have handshakes and cold hand. I remember this question, what the difference between the tremors of a patient with hyperthyroidism and the tremor of a patient with anxiety. Hyperthyroidism will have a hot or warm, shaky hand, and anxiety will have a cold, shaky hand. When you have anxiety, your hand is cold and sweaty and shaky. Sorry, cold and shaky. Then fibromyalgia, you will ask about uncontrolled blood pressure. It is resting tremor sometimes, and there is weight loss. So for fibromyalgia, weight loss, uncontrolled blood pressure, lost motion. Okay. Here, yellow question, present the common cases appearing in the exam, usually. As I wrote here in this slide, I don't know, I think the one you received didn't include that. For the cerebellum, there is eye, nystagmus, finger to nose, hypotonia, dysdiadochokinesia, rebound, pendular reflex, ataxic gait. The causes of the cerebellum, because if it came as cerebellar, you need to ask, once it is cerebellar, you need to ask about trauma, about alcohol, about meningitis, about weakness, vision, affection of hot bath. Why? Hot bath and vision for the multiple sclerosis. Patients with multiple sclerosis have blurring of vision because of neuritis and pain in moving the eyeball. Okay. Then these symptoms getting worse with the hot bath, and the most common cause of the cerebellar attack in middle-aged woman is multiple sclerosis. So here remember what's called past risk, and I'll tell you what is past risk later on. Okay. The causes of cerebellar tremors. Here, this is cerebellar condition because we will discuss that in the neurology also, cerebellar syndrome. The causes multiple sclerosis. Okay. There is what's called HSCD, ataxic telangiectasia, HSCD. Okay, with Friedreich ataxia. Okay, ataxic telangiectasia, alcohol, cerebellopontine angle tremor tumors, which is acoustic neuroma, very important and coming as a part of neurofibromatosis, posterior fossa stroke, meningitis, encephalitis, brainstem vascular lesion. Again, you don't have a clear mind to hear these details now for the neurology, so later on we will discuss this part in the neurology. Posterior fossa space of mind lesion, paraneoplastic, alcoholic, cerebellar degeneration. So all these can be causes of cerebellar. The most important is MS, alcohol-induced acoustic neuroma, usually, especially acoustic neuroma when part of neurofibromatosis. I will let the patient extend his arms also and check for sweating because of the hyperthyroidism. I'll check the neck for the goiter. I'll check the eye for the jaundice. I will check the abdomen for liver disease. I'll check the lower limb for swelling. And this is for the case of tremor. If I'm going to examine it, I will show him that I'm going to examine this stuff. I will do the cerebellar examination and I will do the thyroid, just a little examination, just to check one from everything to show him that I know what I'm doing. Again, how to use the mnemonic, just write it in your differential and follow the same approach. Follow your approach, and when you come to this point, just go and go through the differential you have in this part. Okay? Give me 2 minutes and I'll be with you. 2 minutes. Okay, doctors. So this slide is very important, and this is one of the most common diseases that you may see in the neurology, as I told you, in station 5. And this is about Parkinsonism and how to deal with that. The patient with Parkinsonism coming with recurrent fall, gait, tremors, and you need to know exactly how to examine the patient, what to ask about. And if you ask me why usually I have lectures for neurology, okay, why not in cardiology, why not in respiratory? Because cardiology, respiratory, and abdomen, it's the same examination, but you only need to study the disease and you need to see patients. So there's nothing to discuss actually. There's some stuff to study yourself from any book, then you will go to examine some patients in clinical course, and that's it. But for the neurology, every case is different. You need to examine upper limb here, lower limb here. You need to find sensory here, motor here. And the problem that most of the candidates that not practicing neurology, they're struggling with it. Although my discussion of the neurology is not enough, it will not cover that you need to see the patient yourself in a clinical course and examine him and get the finding. But at least instead of going and spend time understanding what is the upper motor, what's the lower motor, what is the proximal myopathy, what is the type of cervical, what is the cervical myopathy, what is the hemisection of the cord, you will have all these discussed in the course. You know that exactly what it means and what I'm going to look for. Then when you go to examine the patients, you know what you are looking for. So instead of the stress of understanding what they are discussing, you will be ready for just to search the patient and examine him in the appropriate way. Why I'm saying this introduction? Because Parkinsonism is very important, and Parkinsonism is one type of the cases you may just find in the station 5. Examine this patient in station 3. Examine this patient's lower limb and proceed as appropriate. That's it. So you examine the lower limb, you will find rigidity. Okay, you will find bradykinesia in the hand, for example, whatever he would ask you to do. Okay, then you will proceed by this examination. So I want you to do with Parkinsonism, the first, remember how to examine this patient and how to ask. In station 5, you will be able to talk to the patient. Station 3, you will not be able to talk to the patient. In station 5 or station 3, look to the patient face. You'll find 3 things in the face, 3 things in the hand, 3 actions, and 3 plus. The 3 things in the face is expressionless face. So if you look at the patient, there is less wrinkling, there is no expression. You can't see if the patient is happy or sad, okay, or angry or whatever. He has just expressionless face. Okay, it depends on what is the condition or what is the stage of his disease, but usually they have a blunt, expressionless face. Then glabellar reflex. The glabellar reflex, not all the examiners like it. Some of them will tell you go ahead and do it, and some will tell you no need. So remember to ask the examiner first. Tell him I would like to do the glabellar test. And what is the glabellar test for the new doctors? You will go beside the patient and put your hand from behind his head and start to tap on by your finger in his forehead. The normal person, when you tap in his forehead, he will start blinking 1 or 2 times, then he will stop blinking. Okay, don't do that in front of his eye because anyone will keep blinking if you see your hands going to his eyes. That's why you will come from behind and start tapping on his forehead. Okay, in Parkinsonism, the patient will keep blinking. So you will keep tapping and he will keep blinking. And the normal person, the patient just blink 1 or 2 times, then that's it. Okay. The third thing is dripping of saliva. The patient may be dripping saliva, and we can say also greasy skin. The patient may have greasy skin. When you see, you will feel that his skin is oily. It looks oily and shiny. Okay. So this is about the face. About the hand, you start to examine the arms. You will try to flex and extend. You will find rigidity. There will be cogwheel rigidity. Okay, or there will be a lead pipe rigidity. So it's like it's a piece of a pipe. Okay, this pipe. So it's very rigid, or it will be moving like step by step. Okay, like a cogwheel. In the upper motor neural region, we call it clasp knife rigidity. The clasp knife rigidity is a different type of rigidity. It is something resistant, then it will be relieved. Do you know the clasp knife in Arabic, for the Arabic speaking doctor, al-matwa? The clasp knife, this is al-matwa. When you are trying to close it, there will be resistant, then it will be popped, it will be closed. Okay? I don't know if your generation see this, if you see this matwa, because the young doctors maybe don't know what is the matwa or matwa al-ghazal, but for us, we know it. So this is called clasp knife. Okay? So this is the type of rigidity, and this is the type of rigidity of the upper motor, and the cogwheel and the lead pipe, the rigidity of the Parkinson's. Dr. Adam saying, I didn't see matwa. Yes. You're lucky you didn't see it, Dr. Adam. Maybe if you work in any ER in Egypt, maybe someone will come with matwa. Okay, so the other thing is bradykinesia. I see in UK and I see in the United States also, the people, they like this type of weapon, the white weapons or knives, because they can carry it in their pockets and it will not hurt them if they put it in their pockets. So they like the clasp knife. Yes. Dr. Imam said he's still young, Dr. Adam. So bradykinesia means slow movement. You'll ask the patient to count in his fingers. Okay, I mean, he start counting in his fingers, and usually he will be very slow in counting in his fingers. And then the tremors, the resting tremors, which is the tremors on one hand, usually unilateral, and you can increase this tremor by distraction for the patient. If you start to distract him or let him count in one hand, the tremors will increase, will be obviously increased on the other hand. So this is the 3 things in the hand. Then the next 3 actions: let the patient walk. It will be super slow. Let him write. Maybe he will tell you no need, but ask him to write. There will be micrographia. He will start normal, or he will be writing very small font. If you see the essential tremor patient writing, he will write a big font, big irregular font. This will be very small font. If you ask him to speak, he will speak in monotonous speak. So, what's your name? My name is Mohammed. I'm living in like that. It's the same monotonous speaking. Then, remember, in this point, don't let the patient walk before you finish everything you want. Because usually, if you ask the patient with Parkinsonism to walk early, usually you will be crying beside him. He will move very slow. He will go far from the bed and coming back. Remember, there is no excuse in the timing. I mean, even the examiners can't spend 1 second with you after the bell. So if the patient moved slow for 5 minutes, then he came back, you lost your time in the station. So don't let the patient walk unless you finish everything. If he is Parkinsonism, I mean, because he's super slow. For other things, let him walk the first thing. But for Parkinsonism, okay, be sure that you finish everything. Otherwise, you'll be crying and you want to push him to send him back to the bed. So then 3 plus, because I imagine one patient, one candidate, who told me I was really going to push him by my hands. I was going to push him to sit in the bed because he spent 5 minutes. So then the 3 pluses, okay, will be upward gaze. You ask the patient to look up, okay. Postural hypotension. You will ask the patient if there's dizziness in standing and changing his position. And the 3rd thing is cerebellar, okay, symptoms. And they'll tell you what I mean by that. I mean, the Parkinsonism could be only Parkinsonism, and it could be Parkinsonism as a part of what's called Parkinsonism plus. Okay, based on these 3 things, we can decide what's going on, and you will understand that in the next slide. What I want you to know in this slide, in the first 3 things in the face, 3 in the hand, 3 actions, and 3 plus. The 3 plus, you ask the patient look up, then check the patient blood pressure, and ask him about dizziness, then cerebellar examination. Why? Because of this slide. In this slide, there is something called Parkinsonism only disease. This is Parkinson's disease. So this is Parkinson's disease, nothing, only Parkinsonism. Then sometimes there is Parkinsonism and cerebellar symptoms. Cerebellar symptoms include the Danish and pyramidal symptoms and autonomic failure. So this we call it multiple system atrophy or vascular Parkinsonism. What means that there is a stroke or there is blood clot that affecting the pyramidal tract, okay, affecting the brain also, and affect the basal ganglia, okay, and the substantia nigra. Okay, then it causes Parkinsonian symptoms, but affecting the cerebellum as well and affecting the pyramidal tract. Okay, there is autonomic failure. So we call it multiple system atrophy. When Parkinsonism with dementia, it could be what's called Lewy body dementia. With Parkinsonism and the patient has upward gaze defect, it can be part of what's called progressive supranuclear palsy. Again, you don't need to keep all this in your brain now, but later on you need to understand what was that. Okay, then unilateral Parkinsonism plus asterignosis. Okay, the asterignosis. This is written. There is typo. It's asterignosis. When you ask the patient to close his eye and you write in his hand number, he can't recognize it. And this usually happens when there is basal ganglia and the brain, there's degeneration in both of them. This is called corticobasal degeneration. Corticobasal degeneration. Don't bother yourself with these details now. It is not the suitable time for that. We'll move fast through that in our neurology as well with the same slides. But at least remember that Parkinsonism is only Parkinsonian symptoms. If it is pyramidal or cerebellar symptoms, it will be vascular or multiple system atrophy. If with dementia, it is low body dementia. If with upward gaze, you will consider progressive supranuclear palsy. If with asterignosis, corticobasal degeneration. The causes of Parkinsonism could be idiopathic. Tell the patient to look up. Okay, the patient can't look up, doctor. Causes, okay, of Parkinsonism could be idiopathic, could be Parkinsonian plus, like what we just discussed, the causes, so multiple system atrophy, progressive supranuclear palsy, Lewy body dementia. Then drug-induced medication that can cause Parkinsonism, like metoclopramide and phenothiazide. Okay? And brain damage, patient with history of trauma, post-encephalitic, anoxia, okay, patient was drowning or something. This will be all related to can cause Parkinsonism. For the treatment, you don't need the details like type 1 and like part 1, part 2 of the MRCP. But remember, L-DOPA and C-DOPA, dopamine agonist, COMT inhibitor. Okay, then now amantadine, and if asked about surgical measures, it's deep brain stimulation. So this slide you can read anytime. It is not hard. I make it simple instead of reading from different sources. Okay, so I'm just trying to give you the source of the stuff. So these are what I call it. This is what I call the tremors, the most important tremor extension of Parkinsonism. But you need to remember Dr. Wilson help. Dr. Wilson help is super important. Okay. The last thing for today. Tell me about your battery. What's your battery charge now? Battery charge. Dr. K said 20%. Dr. Imam asking about diagnosis of Parkinsonism. Parkinsonism diagnosed clinically. There is something called SPECT. Okay, there's something called SPECT, which is type of scan, nuclear scan that done for the brain. This only to differentiate if we are confused between both of, if it's not classic Parkinsonism, we do what's called SPECT brain scan. Okay, but actually this is, even the insurance not approving that, and it is not documented in everywhere that it is useful, but still you can consider some imaging like SPECT, but imaging is important to exclude the other causes. So you need to exclude the vascular Parkinsonism by MRI, but don't mention that MRI to diagnose Parkinsonism. We can say, I'm going to request imaging to exclude the other causes, okay? You have empty battery, Dr. Sharif, Dr. Ahmed 10%, Dr. Adam 15%. Okay, so let me tell you something and we will be done. There is one case that usually appearing in the exam, and it is related to the loss motion we discussed today. In this case, every night they bring the case. They try to play with the case. I was going to play this game with you today, but the problem is that you have no battery. So I will just tell you what is the story of the case. This is a Mrs. X and returned home from a trip. This trip was going, she was in India, she was in Kenya, anywhere. And the patient coming back with chronic bleeding, chronic diarrhea, and loss of weight. And this is, and they give you any history of attacks of loose motion while the trip, but she has blooding coming with bleeding with the stool while they're in their trip. So anyway, what I want to highlight that sometimes they like to play in this case, and you will be confused with traveler diarrhea and malaria infection and inflammatory bowel sign, inflammatory bowel disease. Usually this case came many times. Eventually, this case, sometimes they brought it as inflammatory bowel, sometimes just irritable bowel. So I want you to go through the page of the diarrhea and to take care of the duration. I mean, very important to ask the patient, if the loose motion started before you travel, do you have any bleeding with the back passage before travel? Any symptoms started before travel? So if anything started before travel, so it's not malaria and not infectious, or not malaria and not traveler diarrhea. So you need to make a clear, deep analysis of the duration that the symptoms started. And remember, sometimes there's a chronic cause of diarrhea and acute cause in the top. So what the problem? Patient with Crohn's disease, they can simply get infection while they are in Kenya, right? They can get malaria while they are at Kenya. They can't take any medication that can cause loss motion. So remember, patient on antibiotic, for example, okay, and they get loss motion, okay, but they have a history of bleeding per rectum before that by 2 months. So we still within the inflammatory bowel disease. So this case is important because they play this game with the other. So here the key is the duration, the timing of every symptom. So start, when was the last time, when was the first time, when did you notice the blood, was that before you travel or not? They like this game. One few at least will get this case. So you need to be smart enough to check the timing of such cases, okay?